daily clinical practice. So acute aortic syndrome is divided into three entities: aortic ulcer, intramural hematoma, and acute classical dissection. It's of importance to see that these two entities can propagate to each other. Aortic ulcer can go to ultimately to intramural hematoma and then to classical dissection, and or aortic ulcer can propagate to classical dissection. So we have to keep in mind that acute aortic syndrome is not just classical dissection. All of these three entities we have to bear in mind in daily clinical practice. So this is the pathological specimen of patients with dissection of ascending aorta. It's typical intimal tear in a patient in the ascending aorta. In a long-standing hypertension, we can see the big left ventricle with big heavy with septum, and the dissection on the sagittal section, we can see the dividing of the false and true lumen by the intimal tear. So for daily practice and for the guidelines sake, there is a Stanford definition that is dividing the acute aortic syndrome into Stanford type A, that is comprising of ascending aorta, and type B, where the dissection is starting at the descending aorta just below or at the point of the left subclavian artery. So the classical clinical presentation, these are usually men, 2/3 are men in their late 50s with sharp, abrupt onset pain, sudden rise to pain. 2/3 of pain are localized as a chest pain, because classical dissection is in more than 60 to 70% presented as type A dissection, and only about 30 to 40% as type B dissection. And so as the pain migrates, the section moves distally, the radiation of pain moves from the chest to the shoulders and then to the back on intrascapular pain. Due to progression of the section through the false lumen, various extent of peripheral or central venous occlusion can help, and that's we are talking about dissection as a disease with many phases, with thousands of phases, and that's the reason why mass diagnosis, late diagnosis is happening in our emergency wards on a daily basis. So the failure of diagnosis is a major problem. There are typical differences in clinical presentation regarding type A or type B dissection. We were talking about a typical pain. Syncope is one of the main symptoms of type I dissection. Blood pressures can be elevated but can be low or normal. That we have to bear in mind in patients with dissection. Asymmetric pulses, new onset aortic diastolic murmur due to acute aortic regurg, pericardial effusion, pleural effusions, and neurological symptoms. Neurological symptoms, we always when we have combination of chest pain or back pain with paraparesis, hemiparesis, syncope, we have to bear in mind that possible diagnosis is acute aortic syndrome. And distally, as dissection moves distally, we can have renal, intestinal infarction, or even MI, myocardial infarction. We'll see a little bit later. So routine laboratory tests include biochemistry, red blood cell count, C-reactive protein. It's usually elevated in the setting of acute aortic syndrome, and it's not something that is going to bother us unless it is coincided with elevated procalcitonin. Then it means infection. We'll talk about something later about biomarkers, about cardiac biomarkers, about D-dimers as markers of choice in diagnosis, renal function, and all other things. So the first we'll see later is the clinical suspicion laboratory test. We have to bear in mind that intimal flap of the ascending aorta can cover right coronary ostia, so sometimes we can have the picture of inferior myocardial infarction, pericardial effusion with the swinging heart, and we can have the ECG finding of low QRS voltage in standard leads with so-called electric alternance. It's not typical for pericardial effusion. You can have this picture of histogenic cardiomyopathies, but if you have sudden upset, abrupt chest pain, and these ECGs, you have to bear in mind that it might be aortic dissection. So in all patients with this clinical scenario, we have to make so-called pre-test probability. And in case of low pretest probability, we have to make the dimers and some other laboratory tests. So what are the high-risk conditions? High-risk conditions are patients with Marfan syndrome, family history of aortic disease, so history taking is of utmost importance in these people, non-thoracic aortic aneurysm, or previous manipulation regarding the aorta, meaning previous cardiac surgery. You have to keep it in mind. High-risk features are chest, back, or migrating pain, abrupt onset, severe intensity like ripping, like cutting pain, tearing pain, especially in patients, in male patients in their 50s, and physical examination like pulse deficit, systolic blood pressure difference between left and right, focal neurological deficit we are talking about, and new onset of aortic diastolic murmur, meaning acute aortic regurg. So when we have a high pretest or low or intermediate pretest probability, a biomarker that is useful in daily clinical practice, it's very specific, sensitive, with very high negative predictive value, is D-dimer. So the diagnostic value of D-dimer is in acute aortic dissection was valuable more than 10 years ago, and this is a recent meta-analysis that showed that area under the curve is 0.94 with 96% of sensitivity and more than 70% of specificity. So the D-dimers are very accurate in the acute setting to rule out acute aortic dissection. Of course, this is a biomarker together with physical symptoms, with history, and with all of things I was talking before. So this is like an algorithm for acute chest pain. Because the syndromes are overlapping, we have to exclude acute coronary syndromes. If we have hemodynamically unstable patients, we're talking a lot about bedside focus echo. We'll see some pictures later. So we have to perform it immediately in the emergency wards, and proceed with some other imaging techniques, usually CT angio. In stable patients, low or high probability, we are dealing with D-dimers, following by echo and CT angio, usually in daily clinical practice, because according to the IROD registry, at least 2 imaging techniques are performed regularly in patients with acute aortic syndromes, echo being the first and CT angio usually being the second one. Why so? Because MRI is usually time consuming. We don't have it in every county or every hospital around our country, and transesophageal echo is rarely performed anymore because of the elevating of transthoracic pressure and the high risk of rupture. So this is the typical transthoracic bedside echo in an acute setting. We can see dilated aorta with intimal flap. In this initial presentation, we have to seek for the pericardial effusion, left ventricular systolic dysfunction, and we can see this massive aortic regurg. This is the CT angio of the dissection, just starting below the left subclavian artery. And so just to tell once again, according to guidelines, TT is recommended as an initial imaging investigation, usually bedside focus in the emergency wards, followed by some of others, usually CT angio and not MRI or transesophageal echo because of the reasons I mentioned before. So what are the treatments of aortic dissection? In patients with type A aortic dissection, urgent surgery is recommended. In patients with type B dissection, if it's complicated, we'll talk about it in the next slide. What does it mean to complicated type B dissection? And nowadays, TEVR is a recommended method of choice. And in type B, which is uncomplicated, medical therapy should always be recommended. But we have some new issues, some new papers recently. We'll have to discuss something in detail later on. So type A dissection, these are usually surgical techniques. We are not going to go into detail, but this most complicated one, like frozen elephant trunk, it can be proceeded with a TEVR up on the surgical interventions for the treatment of descending thoracic aorta. So the method of choice for type B complicated aortic dissection is TEVR, and if the point of dissection is just nearby the left subclavian artery, we are usually combining it with extra-anatomical carotid subclavian bypass to prevent spinal cord or cerebral injury. So this is our patient with type B dissection. We performed MRI, and there is an intimal tear just on the level of left subclavian artery, and after TEVR, everything went good. We have to think about biomarkers. So we were mentioning D-dimers in the diagnosis. We have to mention some others like troponins. Troponins are positive in up to 30% of patients with acute aortic syndrome. So every third patient with acute aortic syndrome has elevated troponin value. It's of importance regarding differential diagnosis, but even in prognosis, because patients with elevated troponins have 2.5 higher risk of in-hospital mortality in this setting. Brain natriuretic peptides are behaving in the same manner. So patients with elevated brain natriuretic peptides in the setting of acute aortic syndrome during hospitalizations have 4 times higher the risk of in-hospital mortality. So what are the unfavorable prognostic factors? In type B, it's a malperfusion syndromes. We're talking about it, about cerebral spinal injury, acute renal mesenteric injury, or leg ischemia, hypotension shock, refractory pain, because refractory pain means the moving of the tear and propagating of dissection, persistent non-curable hypertension during treatment, and peri-aortic hematoma. We have to keep in mind that peri-aortic hematoma, like one of the signs of contained dissection. Type A, hypotension shock, neurological deficits, acute renal failure. So always acute renal failure is a bad omen. Age, and always keep in mind in differential diagnosis, in prognosis, about cardiac biomarkers. So nowadays, algorithm has changed a little bit. This is one of the position documents of the last year. So if we have complicated type B dissection, and we're talking about what does it mean, it's an indication for emergent TEVAR, but we can prolong TEVAR up to 3 months in certain circumstances that we know that are connected with bad prognosis on the outcome regarding the aorta remodeling and regarding the poor outcomes. That means primary entry tear more than 10 millimeters, primary entry at the inner curvature of the aorta, thoracic aorta of more than 40 millimeters, and false lumen diameter of more than 25 millimeters. So that these are entities that are connected with the bad prognosis on the long time, so we can consider TEVAR up to 3 months after the initial event. Now we are going to talk something just a little bit about other two entities, namely intramural hematoma of the aorta. It's consists about 10 to 25% of patients with aortic syndrome as a consequence of rupture of vasa vasorum. Just opposite to classical dissection, the most type of intramural hematoma of type B, meaning that is involving the descending thoracic aorta, and only about 30 to 40% of type A. This is the typical pathological specimen. And predictors of complications of intramural hematoma are aortic diameter more than 50 millimeters, thickness of more than 11 millimeters, and recurrent pleural effusion, or penetrating ulcer. We have to keep in mind that penetrating aortic ulcer in combination with intramural hematoma is a bad omen and is usually indicated for urgent TEVAR. So, in all patients with acute aortic syndrome, pain relief, antihypertensive, and pulse control with beta blocker is the therapy of choice. Type A intramural hematoma needs urgent surgery, like type A dissection. In type B, depends if it's complicated or it's not complicated. The third entity, the rarest one, is penetrating atherosclerotic ulcer. Only 2 to 7% of all patients with acute aortic syndromes, usually elderly with comorbidities and advanced atherosclerosis, and it's predominantly type B dissection. It can propagate or evolve to classical dissection or intramural hematoma, and this is the typical specimen. And bad signs, we have to calculate, to measure some measures of metastatic ulcer of the classical CT angio, and its depth more than 10 millimeters and 20 millimeters in diameter, predisposing to high risk patients that are needing TEVAR. And the management nowadays, according to guidelines, in type A, surgery should be considered. In complicated type B, TEVAR should be considered. So we are not very sure regarding penetrating ulcer, although we have to keep in mind all those things regarding diameters, penetration, and combination with intramural hematoma that are meaning bad phenotype for rupture or for propagation to classical dissection. So regarding long-term follow-up, when we cure, so-called cure with TEVAR or classical surgery of type A dissection, these patients have to have long-term, long-life surveillance at 1, 6, and 12 months interval than yearly regarding some of the imaging techniques, primarily CT angio or MRI. So these are our patients for lifelong. And to summarize, acute aortic syndrome is frequently misdiagnosed, life-threatening condition. we have shown a simple diagnostic algorithm that can support clinical decision making and avoid misinterpretations of imaging findings, late diagnosis and misdiagnosis, and we have to manage these patients in high volume centers that can improve clinical outcomes. And what about epidemiology? This is one Canadian study that follow up the patients for 12 years. And we can see that the problem is going to rise in the following decades due to the aging population, maybe better to do better diagnosis or something other, but the number of patients with dissections and aneurysms are rising. Nowadays it's about 4 to 5 patients of a population of 100,000 per year. So it's a very rare, but as I told you, it's a disease with many faces, with thousands of faces, and it's still a diagnostic challenge in the 21st century. Thank you very much.